NAPLEX video number 7. Oh my gosh, it's crazy. Okay, today we're going to talk about anticoagulation and venous thromboembolisms. So what is a venous thromboembolism? It's a clot. It's a PE plus a DVT, so one of the two. Usually PEs come from DVTs. They break off and then they go to the lung. DVT symptoms: unilateral pain, swelling, erythema, and tenderness in the lower extremity. So whichever one has the clot. Pulmonary embolism symptoms: chest pain, shortness of breath, tachypnea, dyspnea, hemoptysis. You could throw up blood. That's cray-cray. Risk factors for VTE: reversible and irreversible. Reversible would be like if you're using contraceptive that contains estrogen, stop that nonsense. Recent orthopedic surgery, smoking, prolonged immobility, so long plane rides or car trips. Irreversible risk factors: cancer, you have a coagulant state, hypercoagulant state when you have cancer, thrombophilia, or a history of VTE in the past. So now we're going to talk about the treatments. There are 4 different categories. There's indirect thrombin inhibitors, factor XA inhibitors, direct thrombin inhibitors, and then vitamin K antagonists. So we're going to start with indirect thrombin inhibitors, and that's heparin and low molecular weight heparin. They activate antithrombin, which inactivates factors 2, 10, 9, and 7. How do I remember that? I remember 10, and then I remember 9, and then 2 and 7 equal 9. Both factors 10A and 2A are the main components responsible for anticoagulation activity. So they're equally inactivated by heparin, but with low molecular weight heparin, 10A is 2 to 4 times more likely to get bound to. It's more potent for 10A than 2A for low molecular weight heparin. Heparin's IV or sub-Q. You need to monitor APTT and anti-10A concentrations. Low molecular weight heparin, once a day or twice a day. Sub-Q, no monitoring. You don't use it if creatinine clearance is less than 30. And there's a black box warning for this bad boy. For epidural anesthesia causing spinal hematoma and long-term paralysis. So don't use this in surgery. Side effects: bleeding, but it can be reversed by protamine sulfate. Heparin can also cause osteoporosis, skin necrosis, hyperkalemia, and elevated LFTs, and that's usually if you use it for a long time. Now we need to talk about HIT, which is heparin-induced thrombocytopenia. It's when your platelets drop super low, about 15% decrease, in 5 to 14 days of therapy. It can decrease in 24 hours if they've been exposed to heparin within 100 days. So what do you do if they have HIT? DC heparin. Start fondaparinux. Or you can also start direct thrombin inhibitors, argatroban and bivalirudin. That's the indirect thrombin inhibitors. Now we're going to the factor 10A inhibitors. We've got fondaparinux and then the DOACs: rivaroxaban, apixaban, betrixaban, and edoxaban. So for fondaparinux, it binds the antithrombin inactivating 10A. It has a rapid onset and a long half-life. Now, rivaroxaban, apixaban, and betrixaban and edoxaban, they bind factor 10 directly. They're oral. They're for treatment of DVT and PE. Rivaroxaban and apixaban are also approved for prevention after surgery. You want to avoid these bad boys if the creatinine clearance is less than 30. For apixaban, you can be on full dose for DVT, PE, full dose apixaban if they're on end-stage renal disease. But if it's for AFib, if the apixaban's for AFib, then you'll reduce the dose by half if the 2 of the 3 occur. 2 of the 3. So 2 of the 3 have to be there for you to reduce the dose. A serum creatinine greater than or equal to 1.5, 80 plus age, or less than or equal to 60 kilograms. And then there's some CYP3A4 and P-glycoprotein interactions. Now, direct thrombin inhibitors. We've got argatroban and bivalirudin, as well as dabigatran. Argatroban and bivalirudin are preferred agents for prophylactic and treatment of HIT. So remember, if you have heparin-induced thrombocytopenia, use these bad boys. Side effects: bleeding. You want to avoid argatroban in hepatic dysfunction, and bivalirudin is primarily used in cardiac procedures. Then we've got dabigatran, or Pradaxa. It's PO. Indications for AFib, post-op prophylaxis, and then VTE treatment after 5 to 10 days of IV anticoagulation. It's VID, no monitoring, dose reduction for creatinine clearance 15 to 30. Side effects are bleeding, but luckily we have a reversal agent, idarusizumab. It can also cause dyspepsia, and there's P-glycoprotein interactions. Now let's move on to warfarin, vitamin K antagonist. It inhibits the activation of vitamin K-dependent clotting factors, 2, 7, 9, and 10, and inhibits anticoagulant proteins C and S. It takes 5 to 7 days to work. It's used in combo with IV until an INR level is reached. INR goal is 2 to 3 unless there's a valve replacement or you failed that INR goal before. For genetics, if you have a 2C9 or VKORC1 mutation or polymorphism, you'll require a lower dose. There's a bleeding risk. Drugs like NSAIDs and antiplatelets, history of GI bleed, advanced age, and concomitant disease states increase the bleeding risk. Reversal, vitamin K, if you can wait. So vitamin K, you can give it IV or PO, and that's more for, it's elevated but they're not bleeding. You can give fresh frozen plasma and PCC as well, which is complex concentrate, prothrombin complex concentrate or something like that. Interactions, CYP, impaired absorption, degradation of clotting factors, inhibition of cyclic conversion of vitamin K. So there's lots of drug interactions with warfarin, and you're just going to have to learn them. There's lots of different ways. And then diet. Warfarin interacts with green leafy vegetables high in vitamin K, and if you eat high vitamin K diet, it decreases the INR because there's more vitamin K available. So that is VTE. Catch you next time.